On behalf of Crossroads, I want to thank all of you for tuning in tonight. We know that everybody has a busy schedule, and we appreciate you being here this evening. We have our list of esteemed speakers here tonight, and there's basically your agenda that I won't take the time to go through. I'm trying to fast forward here. There we go. So we're gonna focus tonight on lesser TMT pathologies. So it's interesting when we look in the midfoot, you know, obviously you have 5 TMTs, and the lesser metatarsal TMTs make up 2nd, 3rd, 4th, and 5th. But I think over the years they've kind of developed a complex because they get very little press in the literature and in publications. Maybe it's because they're called the lesser TMTs, but you know, they don't get as much in the press as the first TMT does. So tonight we're going to pay a little respect, a little homage to the lesser TMTs. So we've all seen before, probably one of the most common things we'll see is arthritis in the midfoot, commonly in the lesser TMTs. This can be seen as post-traumatic primary arthritis, sometimes rheumatoid, sometimes even autoimmune, such as lupus. Then we'll also see Lisfranc injuries, which, you know, in the films here on the that we see here on the left, that one's so badly comminuted and fractured that I think most people would probably fuse that. And then we'll go into a little bit about metatarsus adductus and how that plays into things. And actually, it goes hand in hand in many cases with some of the first TMT pathology that we'll see. So when we look at some of the different things that we can use as far as fixation, we can look at using screws only, plates only, and then sometimes staples only. When we look at the Lisfranc ligament, what we know is it's the main stabilizer in this portion of the foot. And really all the bones in the midfoot have ligaments connecting that, with the exception there are no ligaments between the first and second metatarsal. And for this reason, it kind of sets up a little relative area of weakness. When you have the right force, you'll get a Lisfranc injury. And what we know with those, whether we fix them or fuse them, in many cases, they can go on to develop arthritis long-term. When we look at some of the arthritis, we can see that a lot of that's going to occur throughout the midfoot. Sometimes it'll be in conjunction with the first TMT. Other times it'll be all alone and by itself. And then when we start looking at, you know, at metaductus and what effect this has, a lot of cases we'll see this metaductus, and sometimes will be arthritis associated with that, and sometimes not. When it comes to understanding that in the cases where we want to try to correct that, that can be done through the joint with a wedge cut type fusion, or it can even be done with osteotomies. And one of the other things is a lot of times these patients are going to have lesser MTP pathology, and having that bone more straight is going to make it much easier to reconstruct anything that you might be doing with the lesser metatarsals at the MTP joint. So when it comes to metaductus, they're not always symptomatic. They're not going to come in and tell you that, you know, my toes are pointing this direction and that hurts. But we do know that because of that metaductus, particularly at the second, that if we're going to fully correct our hallux valgus deformity, we have to be able to move that over if we're going to be able to fully correct it over time. So if you're going to correct the metaductus, you want to be able to get 15 to 10% better bunion correction by addressing the metaductus. And you have to ask yourself, is it worth opening the can of worms to do that? I'm going to say the answer is yes. And you know, the other thing is, if they already have some arthritis there, in many cases they're symptomatic. And then you're really taking care of 2 issues, the deformity as well as the pain. What about the 4th TMT? We'll discuss this tonight. I think a lot of people, there can be some different schools of thought, but a lot of people like to leave those joints supple and moving. And a lot of times, if you can achieve good stability in a case of arthritis to the 2nd and 3rd TMT, a lot of times keeping those joints mobile. But we'll hear what the panel has to say about that later on this evening. So this is a case of mine recently. This is a 58-year-old female who's got post-traumatic midfoot arthritis, predominantly the 2nd and 3rd TMT. Initially, we did some steroid injections. We also did some carbon fiber with a rocker type shoe. We did get a CAT scan over time to help us assess that. And eventually over time, she went ahead with fusion. Here are some of the intraoperative views using the cut system. And when you're down and exposing, what we're going to hear about this, much like a total ankle replacement, for those who do total ankles, you want to go in and remove the spur so that you can visualize the joint. You can understand the true deformity that's in the joint, and this will help you to be able to get the cutting jig in properly so that you can use this instrument. But that's your first step, is removing the osteophytes so you can actually see the joint prior to putting in this jig. So here's our postoperative x-ray. This patient's really only a week out at this point, but here's just an example of the system. And at this point, what we'll do is we'll kind of move on to our next speaker, Dr. Michael Campbell, and he'll really introduce us exactly what dynaMet's all about. And the rest of the faculty will take us through and dive in deep to what this system represents. Dr. Campbell.
Sorry about that. I was having trouble unmuting my computer. Thank you, Terry. Great introduction. Nice case. That looked really good. dynaMet, this is something that we've been working on for the last few years. I'm really excited about it. For me personally, midfoot fusions were always a tedious, relatively painful case. Small joints, hard to compress, not a lot of real estate for fixation. And that's kind of where this all came and was born from. Hopefully a better way to do it. Is there a way, can you guys advance the slides for me, or can I take control of it? Okay, thank you. What is dynaMet? Well, it's a comprehensive set of staple plates with the cut guides that Dr. Philbin just showed us. And it's designed to work in conjunction with the dynaBunion system that's already available. The dynaMet, the idea behind it is for the small joints, lesser TMTs, typically the second and third. It can be used on the first if necessary, but usually we use dynaBunion on the first and do it with it. dynaMet, a couple different things and a couple of reasons that differentiate it from just regular plates and screws or a regular staple plate, because those things have been around. First are the cut guides that are designed for the midfoot joints. These are small joint guides that really precisely take a little wafer of cartilage and just skim the subchondral bone. So there's minimal resection, but it's fast and rapid and a lot easier than trying to do a manual preparation. The staple compression technology is something that Crossroads has been using for years. The idea behind this is it's the plate to provide rotational control and better stability than an isolated staple, but the dynamic compression of a staple to provide gap recovery and better biology for bone healing, especially in the case of fusions where sometimes you get some resorption, or in the midfoot where people walk. I really like this design biomechanically. If you think about the ideal way to fix a midfoot joint is to create a plantar tension band. Dissecting through the bottom of the foot to do that is not practical, nor something I would ever recommend doing. But with this staple plate, the tongs of the staple are what compress, and through a dorsal approach, you create this really neat plantar tension band that squeezes the plantar aspect of the joint. And if your patient walks on it or there's any resorption, it closes the gap down. The staple compression plates to work in the midfoot need to be shrunk. They've come up with a couple different options, and we'll talk about that in a few slides here. dynaBunion and dynaMet, like I said, are designed to address not only the midfoot arthritis, but Lisfranc injuries, hallux valgus, metatarsus adductus, or a combination of those things. The cut guides, the term is slice and vice. Your cut guide goes on, you make your cut. It leaves a wire that you can place a Hinterman over and gives you really nice visualization. You pop out the cut pieces. You can do your joint prep rapidly, and then you put your plate on. And the plate, the rack block, the compression block that you see there on the right side picture, is what squeezes those wires together, creates plantar compression, and goes directly over the plate. The neat part about this is placing a plate in a midfoot joint can be fiddly. There's not a lot of real estate on the cuneiform. The wires by default put the plate in the ballpark of where it needs to be, so it becomes a lot easier. Instruments and offerings. What comes? Well, we talked a little bit about K wires. Those go in through the cut guide. They're 1.6 millimeter wires, so they're smaller than what are used for the standard dynabunion. So they correlate better with the size of the smaller metatarsals, and particularly the third. The cut guide is pretty neat. It has, if you look, can you guys see my? I don't know if you can see my mouse over here, but there's on the this side here, there are 3 holes, and you can choose which one you want to put your wire in on the metatarsal side, because sometimes, especially in a metatarsus adductus, the joint is not perpendicular to the metatarsal. So this gives you the ability to capture the metatarsal with a really central wire, so you get good fixation. After you've done your cuts using the 40 millimeter saw blade that allows you to get through the guide and all the way down to the bottom of a metatarsal, even in a large foot, you then use the Hinterman distractor, which is provided. You can choose your plate. There's a couple options. We'll talk about that. And then you can put your rack block over the top to compress. One other thing probably worth mentioning is some cases you get in there and you don't want to use a plate. Maybe you just want to do an isolated staple. There are these grooves over here, and these will guide a wire that goes obliquely across the joint. You can then take the rack block off, and because it's an oblique wire, it will maintain compression of the joint. So it's nice. This is a typical Crossroads tech, style where you have multiple fixation options. So if you don't want to use a plate, you can do something like a staple. I did one of those yesterday with an oblique wire. It held the fixation. I put the staple in around it. These are the plate options that have been designed for it. And this was quite a bit of research, design, and going back to the drawing board to really find the optimal sizes and shapes. All of the plates are curved in both the coronal and sagittal planes. They're designed to work with a curved staple as well, the Hymax C staple line. There's a 15 millimeter regular, and then a narrow for really petite feet. Then there's an 18 millimeter for larger feet. There's also 15, 18 millimeter straight plates. When I'm saying 15 and 18, what I'm referring to is the size staple bridge that would go in here. So in the 15, these 2 holes, the 2 inner holes on the staple plate are going to be 15 millimeters apart versus 18 millimeters apart. These are the staple options that work with it. For the 15 millimeter plates, you have options of staples with 15 and 18 millimeter legs. For the 18 millimeter ones, you have options of 18, 14, or there's one that has an 18 leg and a 14 leg. This is often the one that we use in the dynaMet. And this works pretty nicely, and particularly in like a third metatarsal. Additionally, you have the options to do standalone implants. The Hymax Plus is a super compression staple. The keel lock is a staple that almost has the equivalent of a plate built in. It provides rotational stability. So pretty neat little choice of options that all work in conjunction with this comprehensive system. So without further ado, I think Dr. Young, you're going to be doing the surgical technique. Is that correct?
This is still you, Dr. Campbell.
Oh, sorry. I apologize. So looking at the surgical technique here, we're going to go in, we're going to place the cut guide, and we're going to pin the cut guide on the metatarsal side. You then go and you make your cut. And if you want, there's the ability, you can place an oblique pin to stabilize it. A lot of cases, I'll just put a little hemostat over the end of it. You then flip it around and you make your cut on the cuneiform side, which you can see in number 2 here. Then if we move down to number 3, you have the Hinterman. It gives you beautiful visualization of the cut surfaces. It gives you room to work in there, so you can pull out the fragments that you cut, and then you can, if you would like to, drill these surfaces for healing. I typically do that. And this is really where I think the system gets neat. You leave those wires in place, and when you go to put your plate on, those wires go through the holes where your staples are going to go. Slightly different than standard Crossroads technique. Typically, we talk about putting the staple on first. In this case, we put the plate down and we fixate the plate on the cuneiform side. And then we slide a rack block over the top of those wires, over the top of the plate. That provides the compression. It leaves the distal hole in the plate open in the metatarsal, and you can go and you can fixate to the metatarsal with a screw. At that point, the rack block comes off, the wires come out, and then you drill and you insert your compression staples. The neat part about this is the joint is already compressed when you put the staple in, so you don't lose any of the staple compressing the joint in the operating room. All of that compression is saved for after the operating room, in case in the event of any bony resorption at the fusion site, or in the event that there's a little bit of dorsiflexion with weight bearing, the staple can slam that joint surface back together and lock it down. So here's an animation. Whenever I start one of these cases, I try to do it. Yeah, I really think one of the keys is getting your incision in a good location. I always go and take an x-ray, no matter how many of these I do, and really precisely pick where I'm going to make my incision. You can see here the paddle going in, the wire going into the metatarsal. Important point, you want that wire to be bicortical so you get good fixation. These are the additional holes that I mentioned earlier. So if you want, you can grab a metatarsal off to the side. The distal hole is an oblique hole that's designed to hold it. You can also put these wires, and this is kind of neat, where it's almost like a side guard where it will prevent your saw excursion. They also have the conventional wires that go in kind of like the blocking wires on a total ankle cut guide. You've made the cut on the metatarsal side. I usually pull that little piece out, makes it easier to stick the guide back in. For the cuneiform cut, that gets pinned, that piece comes out. And if you want to, you can do the same thing for the third. This just shows how easy it is to get the access. And I have a case later where you can see an intraoperative picture of what it looks like. And it really does just look like the animation. You get these incredibly congruent flat cuts. And then the fixation options, the straight plates, the linked plates, or the Hymax plates. All of the sets come with a set of templates. So you don't have to burn a plate. If you pick the wrong one, you can use the template and place it over your wires, figure out which is going to be the best option for your case that you're doing and the anatomy of the foot that you're doing. They talk about the plates of J and L on the linked plates. It's a way to describe them. And here, this just shows the coronal bend and the contour. These are the templates, which are nice and they're metal, so they show up on the x-ray. They're exactly the same as the regular plates. The other thing too is we always put the Hymax C staples in, which are the curved staple to match the contour of the curved plate. They have nice olive tacks that go in there if you want to hold it. Quite frankly, with the wires in place, a lot of times you don't even need that. For fixation, whenever you're doing staple compression plating, biomechanically, it's advantageous to use non-locking screws. You want to give the staple the ability to be able to move the bones and the plate slightly. So I almost always, unless the bone is exceptionally osteoporotic, try to use a non-locking screw. My trick that I do is if I know that the bone's osteoporotic, like the case I was doing yesterday was a 72-year-old petite female who had pretty soft bone. I was drilling with the smaller drill bit. There's a 2mm drill bit and a 2.5mm drill bit. I was using the 2mm drill bit, which typically is coupled with the 3mm screw, and I was using the 3.5 screws with it. This just shows the rack block placed over the proximal screws, leaving the distal holes open. So you can fixate those, then everything can come out, and you've maintained, at this point, you've got a stable construct, and you drill. The drill guide, the 3.2mm drill bit for the staple is neat because it has markings. So when you put it through the that drill guide, you can see exactly how deep you're drilling and drill to the appropriate depth. And the staple goes in. This inserter keeps the staple extended until it's fully inserted, with the exception of the last millimeter that you then drive in with a little tamp. And when you're done, this is what your construct is going to look like. It's low profile, extremely stable, and really, really small. You can get, 2 points of fixation in a relatively small cuneiform bone. Here's a case where you're, same idea. You have your rack blocks in place. If you want to do a staple, like I did yesterday, you can throw an oblique wire like this, which then, because it's oblique across the joint, you can take out your rack block compression wires, and it maintains your compression for you. and then you can drill and insert staples around it, or if you need to, you can come in from the side. A lot of times, if you're doing that, it's nice to use the Hymax Plus, which is an even higher compression staple that really gives a lot of power. This works really nicely in strong bone. These things have quite a bit of squish available when they close down. All right, and moving forward here. And I'm going to pass it along here to my buddy, Dr. Shawen from Ortho Carolina. Scott, take it away, my friend.
So, we've kind of gone backwards with this. We've already talked about the new techniques utilizing these cut guides. So I'm going to talk a little bit more about, traditional preparation, and then how we progressed to this point. I don't know, Scott, there you go. And so, traditionally for about 15 years, my joint preparation was like most of yours, I'm sure, where it was curettage technique. You get into the joint, well, you find the joint first, take off the osteophytes, get into it, and then scrape away what remains of the cartilage, and then try to then potentially correct any deformity with minimal cuts. But most of the time it was not being able to correct any deformity. This is a little more time consuming. You're using more crude instruments. It's less precise. You also have, I think, a harder time getting into the plantar aspect of the joint, and may not get through that subchondral bone, which you need to get through in order to provide ideal bone for fusion, or bone that has good blood flow to it. So the challenges that we had with that a few years ago, one of my partners, Ken Ellington, suggested utilizing a small sagittal saw in the preparation of the joints. And I liked that idea. You had better access to the cancellous bone for fusion. We more consistently prepared the plantar aspect of the joint, but the downside was that these were freehand cuts that were more difficult to control, and you possibly remove more than the minimal bone. The other thing is, I work with residents and fellows, and that's always a little bit of a concern when you're allowing a second-year resident, see one, do one, teach one, and that is very difficult. So while we were developing the dynaBunion system and the cut guide, we thought, wow, this would be perfect to transition or translate to the lesser metatarsals, and that has really worked well. And so again, these are controlled cuts that take minimal bone, and it is much quicker than the curettage technique. And really, frankly, it's quicker than doing a freehand technique in most cases. So again, we're looking at the lesser metatarsal. We have to come in, prepare the joint. You're loosening the ligaments around it. You've got an osteotome, getting down and making sure that you can see all the way to the bottom. You've either got a hinterman or a small retractor, scraping away, again, what remained of that cartilage. You may have bone that is not truly conforming also. So let's see here where we got. So again, we have newer techniques that Mike has already gone through in detail. Again, with the first TMT, we have the dynaBunion, and then now we have this lesser cut guide. And you really are taking minimal bone with that paddle in place. Again, you can see that's 1.6 millimeters max that you will take. You can do some recuts if you have to. And there are some other compression guides that are available if you need to do that. So this is a case, a 40-year-old guy that fell from a height, landed awkwardly, has a first TMT fracture at the base of the medial cuneiform. What wasn't included in this, there's another CT cut that demonstrates that second metatarsal is plantarly translated and fractured. And so a true Lisfranc injury, and also the third TMT joint is dislocated dorsally. And so, this is the same technique. I use manual flat cuts because I didn't have access to the cut guides in this case. And so, we came in with flat cuts. And so even that second metatarsal that had a fracture at the base, I'll do flat cuts with that because I find it's easier to remove the cartilage that are on those fracture fragments with an oscillating saw than it is with trying to put a curette in there or a rongeur. And then I'll finish it up with a rongeur as needed. And then, of course, doing the drilling that we discussed earlier. This is a little more difficult case. You've got a lady with metatarsus adductus. You can see that she's had a stress fracture of the fourth that's healed, but an acute stress fracture of the fifth. And so, with these type of cases, again, this is something that we're developing would be cut guides that are going to help you to be able to resect these metatarsal bases at an angle. But we came in with freehand cuts and cut the second and third metatarsals, came back and did a dynabunion on the first, and then we're able to reduce that and hold those metatarsals in place. We then came back and resected the base of the fourth and the fifth in order to allow that portion of the foot to rotate over and up. And we actually had to, in this case, resect the fourth and the fifth in order to get that space. And we put an interposition allograft with tendon and put in a screw, like a Jones screw, through our resection base at that time. So this one's only about 6 weeks out, so I don't have any final x-rays at this time. But again, we're developing better ways to be able to address metatarsus adductus and cut in controlled measures, so you won't have to do freehand cuts in the future. And I'll go ahead and hand this over to Dr. Evan Young, and he'll discuss more compressing the lesser TMTs.
Thank you, guys. Interesting case there. That looked very challenging, to say the least. So when you're trying to compress these joints, I can't tell you how many times when I first came out of residency that I struggled getting good compression across the midfoot joints. And, we've already shown in multiple slides how well this system works at getting nice flat opposing surfaces that are truly opposing with good compression. I was found to get the planar half of the joint as the most difficult part of the procedure. Always found a lot of dorsiflexion of the metatarsals was a common mistake I was getting as well. So you don't have a lot of medial to lateral restriction, or you don't have a lot of medial to lateral movement with these lesser metatarsals. So it seems to be mostly dorsal to planar unless you need to get a wedge cut in there. So these ratcheting mechanisms do give you some struggles for sure, as they were already talking about. So this is one, they're just showing different instrumentation here that basically you got to get it just right. You got to get it centered. You can over dorsiflex, you can rotate it, and the new system works better at controlling some of that. It's very simple. It's rapid. As Dr. Campbell was alluding to earlier, how you remove the rack block and your pins, or you remove the cut guide and your pins are already in place for the rack block, helps you get compression rather quickly. These are great systems. I love that you can choose the standard or go up with the compression if you find you just need a little bit more. This is one of my cases I did not too long ago. This is a 44-year-old female. She was retired military working in an Amazon warehouse. At first glance, her x-rays really did not look that bad. And she had been complaining of pain in this foot for 5 or 6 visits, and tried some standard things, orthotics and cortisone injections and some other stuff. She never had a history of injury, but you can see the gapping at the Lisfranc joint area. Went ahead and got an MRI, and she actually had some cystic changes on both sides of the second TMT and at the naviculo-cuneiform joint, which was really where the majority of her deformity was. And I think this is a classical case of hypermobility not being present at the first TMT, but rather at the naviculo-cuneiform joint. leading to second and third tarsometatarsal joint instability and pain. So we went ahead and did a what's called the crossbar technique here on the navicular cuneiform joint, just to get added compression over there, good quick stability, and then did the typical rack block reduction, just like Dr. Campbell was showing earlier. Put the rack block on there, oblique wire to hold it in place, and then two staple fixation. She didn't have any Lisfranc issues on her MRI, so I chose to leave that alone and just focus on getting the navicular cuneiform joint instability under control. Really amazing thing about this case was she came in 4 weeks post-op. She was supposed to be in her splint, but she was already walking in a boot and wondered why I didn't let her walk in a boot the day of surgery. So she was doing that well. Just saw her the other day. She was still doing great. It's like 8 weeks out now, walking all the time. So here's a full case walkthrough. This is actually the first time I did one of these cases. You can see the extremely large bunion deformity was one of the main complaints, but she also had severe midfoot arthritis. The cool thing, you can see these wafer cuts. We made sure to get good pictures of the wafers when we cut those out of there. You can see the Hinterman distractor on there and how much excellent joint exposure you get. So it really does work well. This is sort of as we're going through the case. We took a lot of x-ray and saved all the pictures. Wanted to kind of demonstrate how, if you want to, you can prep all these joints. You can leave your pins in place for all of the compression, and kind of do them in whatever order you want to. Since this was my first time, I was kind of playing around with it quite a bit. So we prepped all three, and then we put the rack block on the first, and then we put it over on the second and third. So just kind of trying to get a feel for what the best series of compression would be. We ended up taking the rack block off of the first and going back and doing 2 and 3 first, and then did the first after we had 2 and 3 all nicely fixated. So here you can see 2 and 3 being done. Excellent compression. After we got those on, did our full dynabunion reduction after we had 2 and 3 reconstructed, and started putting the medially based dynabunion plate on there with the rack block. Here's sort of final construct images. I always try to make sure I don't put the any screws that are going from the first ray into the second or third in between the staples. I don't know if that's super scientific, but it seems to me that it might hinder some of the compression. Whereas if you're outside of the staple, it might help a little bit. So something we could maybe run some studies on. But this was her foot afterwards. Admittedly, could have done a little better job on the Aiken or something like that, but she was super happy with it, which is all that really matters. So turn it back over to Dr. Campbell.
Thanks, Evan. Good case. So, what are the challenges with lesser TMT fixation? Quite frankly, it's typically cuneiform real estate and the small size of the first metatarsal, or I should say the lesser metatarsals. A lot of times you'll see x-rays of, people who do a single lag screw. There really isn't a lot of strength in that. Trying to put a plate on, it's hard to get good compression. A lot of times plates compress dorsally, which is exactly what you don't want when you're trying to fix a first, or I should say any midfoot joint, because it will cause a dorsiflexion moment that will then create a transfer metatarsalgia downstream. The other thing that's really neat about these plates is when you place a lag screw across the joint, you're losing surface area for bone healing. And these are small joints without a lot of surface area. So you want to maintain as much bony contact as possible. So dorsal plating, axial compression, continuous post-operative compression, and biomechanically, you're creating a plantar tension band from a dorsal approach. So here's what I was just talking about earlier, the cross-section of a screw going through a small tarsometatarsal joint versus a staple, which leaves it intact and bridges over the top of it. The other thing too is a lag screw, while it provides nice compression in the operating room, what you have is what you have. I describe it, these staples with the compression is something that is dynamic, and it's kind of like having the ability to go back and every day go retighten that lag screw a 1/16 of a turn when your patient walks on it or moves on it. One of the viewers asked a question earlier. Let me see. It was Blake. So this one is for you, not Blake Moore, my partner. He's on the call too. He was asking about how does a staple compress after you've already locked the screws in? And it's a great question because I was skeptical when I first saw this, and this is an example. This is a dorsal plate with a traditional lag screw, and what you're looking at here are two bone blocks that have a small wafer of ice. The ice melts the dorsal plate with a lag screw. They're distracted. Now here's a staple compression plate construct, just like the dynaMet one. The ice melts, and you catch right at the end, right at the last bit of the ice melting, the nitinol compression staple in conjunction with the flexible titanium plate with non-locking screws, and you get compression and what we call gap recovery. So that, Blake, that's the answer to that question. I said I was going to show that video at the end. I forgot that they included it here. So, and actually, you don't just get angular compression. You actually, looking at this and measuring it, you get a little bit of longitudinal compression as well. So it's not just a plantar compression. The whole construct is actually dynamic and moves, and that's really the neat part about this. This is a case I did pretty recently. I've got 8-week follow-up on this gentleman now, and he's doing well. It's a work comp patient. He was a polytrauma patient. He actually was a construction worker who works nights. He does nighttime road construction, and a drunk driver drove through the construction site and popped him, really messed him up. He came to me. He was seen at the trauma center, and they fixed a tibia fracture on him. He had a displaced Lisfranc injury, and that's when I received him. The pre-op films, he had arthritic change throughout the hind foot. He had arthritic change throughout the midfoot. Those injuries they were chronic at this point. He was treated non-operatively for his foot injuries. Quite frankly, he was in the ICU for so long, they were kind of wondering if he was going to make it. He had virtually no hind foot motion. We really treated him aggressively. He really didn't want to go back to the operating room, but we had to. I'm blessed. I got a weight-bearing CT scan. So these are some images from his pre-op films. They did a really nice minimally invasive plating of his tibia fracture that you can see some of the hardware from. And you can see over here on these sagittal views here, he's got a fair bit of hindfoot talonavicular joint arthritis. When you move down to the bottom right picture here, you can see the midfoot arthritis that he had. So going through this case, like I said earlier, whenever I start one of these cases, I really think for midfoot, if you want to be happy, getting your incision in the right position is critical, or you end up having to make a huge cut, or you end up stretching the skin and ending up with a wound complication. So I always start by checking my spot, and you can see over here this gaposis over here in his displaced Lisfranc injury. These are some x-rays of what the guide looks like in place. When I do one of these, I like to go through, I do a 2-incision technique for this. I do that incision that I showed you centered over 2 and 3, and then I get a little bit more medial than normal for my dynabunion incision. Even though this gentleman didn't have a bunion, I still use the dynabunion preparation. It's really the easiest dynabunion you ever do because you don't have to worry about doing the reduction part of it. This is what it looks like. This is my dorsal incision on the foot, and using the microsagittal saw with the cut guides. I mentioned earlier that you can use the oblique hole to pin it. You can put a second wire in. I don't like putting more holes in the metatarsal than I have to, so I usually just grab a little hemostat and I grab the wire at the clamp. The other option is you can have your surgical assistant put their finger there if they trust you. My nurse practitioner apparently doesn't trust me, so we use the Hinterman. After the joint preparation, after you use the guide and you put the Hinterman on, this is the view that you get. And I think this is just absolutely beautiful. I'd like to think I'm a pretty good surgeon, but I cannot prepare a tarsometatarsal joint for fusion with this type of congruity freehand. I certainly can't do it this well with this little joint resection, and I certainly can't do it as fast as this system allows me to do it. So it's win-win all the way around. This is something that not only makes your job easier, but it makes it faster and better, which is exactly what I look for if I'm going to adopt a new technology in my practice. And then the other fiddly thing with midfoot, especially when you're trying to use one of these linked plates, is getting the plate in the right position. You're always, you have it on the cuneiform, but then it's off the third metatarsal. You have it on the third metatarsal, and then it's off the second metatarsal. These wires guide it. You pick the plate that works the best. You have options, and you lay it down, and this is what it looks like. You can see here before we fixate it, this is me drilling and inserting the screws in the cuneiform, the proximal placement. This is the rack block down over the top of it. When I do this, I recommend placing both rack blocks at once. This was an earlier case before the final system was available. We have 2 0 and 2 1 rack blocks in all the sets now, so you'll have the ability to place 2 rack blocks at once. Here's the distal screw placement. If you want to get even a little bit more compression, you can even drill this a little bit eccentrically if you'd like. And this is what it looks like before you put the staples in. You can see, I think this is a pretty fair x-ray that's got a pretty good shot down where the joints were. It's completely compressed at this point. And now at this point, the staple gets drilled and inserted. And all of that staple compression is saved for gap recovery or if there's any resorption at the fusion site. And this is what it looks like. And I think this is a perfect example of how beautifully these plates are engineered and how nicely they fit the metatarsals. You can see they slide right in there. And then you come back and you can do your dynabunion as well. This gentleman as well had a bunch of hindfoot arthritis that you guys saw earlier. This is his fixation. Off topic a little bit, but I love when I do my triples for the CC joint. They make this Z-shaped plate. I use that. And then for my talonavicular joint, I typically start with a headed lag screw to kind of get my position and hold it. And then I usually come back with 1 or 2 staples, one typically from the sinus tarsi, and if necessary, like this guy's a big guy, a second one from the medial side to really get nice compression all the way across the talonavicular joint. All right, so Dr. Philbin, should we do some panel discussion here? Oh, you're on mute, Terry. Hey, Terry, you're on mute still.
Thank you. Sorry, I was having a hard time hitting the unmute button for some reason. So can you make it so that I have control here? Let's go back a slide, please. All right. So let's go with the panel discussion. Sorry for my AV problems there, but we'll just kind of, start with Scott and just kind of go through the panel. So the first question is, how often are you seeing lesser TMT arthritis in conjunction with bunion deformities?
Yeah, I probably see it sometimes, whether it's symptomatic or not, is less common. I probably do lesser TMTs about 1 in 5 or 1 in 10, somewhere in there, as far as adding that with the hallux valgus. I will say, when you would discuss the metatarsus adductus, I think that there's a much higher incidence of midfoot arthritis at 2 and 3 with metatarsus adductus than there is in the general population. And so, with those patients, when they have hallux valgus, and it's gotten bad enough, I really think that if they're symptomatic, you got to do something about it. So,
Evan, how about you?
Yeah, I see a lot of it. Yeah, I kind of agree. Whether or not it's symptomatic kind of determines whether or not you need to treat it. What I've kind of discovered it just here recently, and in doing a lot of panel discussions and work with Crossroads, is how much the medial column affects the second and third. I think if you have hypermobility in the medial column, you get elevatus of the first met, and you get jamming at the first MTP. And next thing you know, you've got this weight transfer over to 2 and 3 that really contributes a lot to the arthritis of the lesser TMT joints. So when I usually see it, I feel like it's commonly associated with the hypermobility of the first ray. I think I'm becoming more and more aware of the navicular-cuneiform joint instability. Seemed to be something I saw a lot of and didn't understand for a long time. I would just fix it if it was symptomatic. And anymore now I'm kind of looking for it to make sure I'm not missing it, because the last thing you want is to miss something like that and have a patient be symptomatic, beyond doing something simple.
Any more to add, Dr. Campbell?
No, I think I think you guys kind of hit it. That first ray, that medial column hypermobility, that I love Lapidus for treating. I think really helps stabilize and offload the second and third. And I think when you have that hypermobile medial column, you end up with one of two things. It's either transfer metatarsalgia, or in a lot of cases, second and third metatarsal arthritis. If it's not severe, a lot of times I think by just stabilizing the first ray, you can effectively offload and save those joints. But when it's more pronounced, you have to really address them. If you're going to go in and do this surgery on a patient, I think the recovery from 1 versus 3 is not a huge difference. So I'm a big fan, and I think my patients really appreciate the one and done approach if you can do it.
All right. So next question is, how much time savings do you get using the cut guide versus traditional measures of curettage or what have you? And any issues with fusion or shortening? Like, do you take out too much bone with one versus the other?
Yeah, so, I do think it's probably a quarter of the amount of time to use a cut guide versus the usual curettage and debridement and then drilling the joint. The shortening, when I first did my freehand cuts, I was very worried about that. But I was able to get that, to relieve that if you have a problem by releasing some of the ligaments around the base of the metatarsal. And so I haven't seen that problem. And with the cut guides, you're taking even less than freehand cuts. And so I don't really see that as an issue. I do remember the night that Mike and I were talking about this, and we were thinking we were going to have to, put some sort of graft in between the where you did your cut resection, but it's really not the case.
I think one of the tricks too, well, we can talk about that later, but it's definitely faster. I would love to say that I'm an incredible surgeon and I can do it better freehand, but I can't do it as fast. I can't do it as well. And when you couple that with the ability to distract because the wires are in place with the Hinterman and prep and then compress, it's a no-brainer.
Yeah, I feel like I spent the majority of my time just making sure I got it prepped all the way through to the planar aspect of the joint. And with this system, you just stick that saw blade in there on both sides and you're done. So it really does speed that up quite a bit. And then you just got to get that little wafer out of there. 1.5 millimeters is nothing really when you think about the amount of shortening that you're creating, with the most being just over 3 millimeters after you take both pieces. It's really not affecting it much at all.
All right. What are your experiences in using the dynaBunion first TMT instruments for first TMT arthritis?
Well, I'll jump on this one first. That case I showed, that's exactly what I did. That last case that was up, and it's the easiest dynaBunion you're ever going to do. You don't have to really worry about the deformity correction. You're simply putting your cut guides on, making your cuts, preparing and compressing. So it's, quite frankly, it's about a 15-minute case, and it works just as well, I think, as dynaBunion does. So pretty straightforward.
Yeah, I think the hardest thing for me on these is if you go medial with it and you put your medial rack block on, you're kind of, if you want to use the medially based plate, you have to pin it. So if you're a person that likes to leave the rack block on and put your plate on, You might struggle if you're on the medial side, if you have a second incision over the dorsal aspect. But that's really splitting hairs. In my opinion, I think for the most part, I love how this works. And like Dr. Campbell said, if you don't have to worry about transverse plane deformity along with frontal plane, and you're just putting this thing back together, it's just 2 cuts and put the rack block on, so makes it super quick.
Yeah, the only difficulty I've had is in a really arthritic joint, it's harder to get it loose. You really have to get the joint ligaments resected in order to get that paddle in there.
All right. So what is everyone's philosophy on the bridging versus fusion in the Liz Frank case?
I'm probably more of a fuser at this point in my career. I think Terry and I are about the same points in our careers, and I started like I was taught, just either doing screws with home run screws, and then doing some bridge plates later, and really have gotten towards fusion. For me, it's a young patient with no fractures that I'll tend to do either a bridge plate or a screw technique.
If it's homomedial or homolateral and there's not a lot of comminution, I'll typically bridge it. But if any one of those 3 things isn't there, divergent Liz Frank, lots of comminution, multiple fractures into any one of those joints, I start thinking fusion pretty quickly.
My personal experience is that I've found that patients where I've tried an ORIF and it doesn't work and I have to go back and fuse it, don't seem to do as well as the patients that I fuse right off the bat. So I'm pretty aggressive at fusing mine. If it's a real subtle one, like in one of my college football players where it's just a sprain that's not displaced that you need an MRI to find, in those cases, I'll do a lot of times like a tightrope type of reconstruction for a very mild one. But otherwise, for the most part, I typically fuse mine because I feel like it's the most reliable option. I won't do transarticular screws. If I was going to fix it, I would bridge plate it. I can't think of anywhere else in the body where I would think it acceptable to fire a screw across a joint and then come back and take it out. So I don't do that in the midfoot. But the bridge plating is, I think, a reasonable option. It's 2 surgeries, and again, I'm a big fan of one and done.
All right. What about 4th and 5th TMT philosophies? Are these joints that we should fuse? We should do interposition? What are your guys' thoughts on these joints?
Well, I think you probably already know what I'm going to say, but I don't fuse these. I do interposition. I used to do ceramic ball interposition. I wrote the paper with Bob Anderson a long time ago when I was a fellow, and those you can't even get anymore. So I just do a tendon anchovy, which is actually, I think, Greg Burlett's paper that was a couple years ahead of me.
Yeah, I've not ever tried to fuse one of these just because I was trained never to do it. And I seem to get decent results with tensor fasciolata grafts, doing the anchovy technique. I think that works great as an interpositional graft. The few that I've done have all done really well. So I just always hope that I don't have to go back there, because it's, trying to get those things fixated where they're going to stay put can be a little bit of a challenge, but still good cases to try to leave open.
Yeah, I find that most of the time you want these, after you do the resection, you want them to float up a little bit, off of the cuboid. And so in the sagittal plane, I'll let them, come up and just try to keep that tendon anchovy in between them.
Yeah, I recently had 2 of these show up in my clinic recently that were had trials of fusions, both non-unions. And what I'm going to try to do to salvage it is to try to convert them into interposition arthroplasties as opposed to trying to refuse them.
So I have a question for you guys, because I'm not going to say that I have the right solution for this in any way, but when you guys do your interpositional arthroplasties, do you do a resection where you take away a nice chunk of bone off the metatarsal so that to create some space?
Yes.
Yes.
Okay. That's what I've done in the past. I'm 0 for 1. I tried fusing these probably the day after my board collection period ended about 11 years ago, and it went miserably. And then I realized why everyone says never try fusing these. So.
All right. Frequency of lesser TMT arthritis versus Liz Frank versus metaductus, and whether or not, it's operative. When you do these operative, what's the frequency? What do you see more, TMT arthritis cases, Liz Frank, or metaductus cases?
I mean, I think it depends on your population, but I see TMT arthritis a fair amount just because of my older population, and then metaductus. I think that has probably been seeing us as far as metaductus arthritis more than we've been really recognizing it, and then Liz Frank is probably third for me.
Yeah, I saw a lot of Liz Frank injury when I first came out of residency. Don't really know why. Wasn't expecting to see a lot of it. And I bet you after my first or second year in practice, it's probably one of the fewest things that I've seen. So, things.
Because your clinic's got full.
Yeah, maybe that's what it is.
I found that if I keep 5 slots open in a clinic every week and open it up the day before, they're all filled with trauma.
Yeah. Yeah, it's quite possible. Yeah, so I mean, now I don't see very much Liz Frank at all. I would say TMT arthritis and then metaductus 1 and 2, respectively.
I definitely see the most TMT arthritis of the 3, and then I see a bit of metaductus. I got to tell you, I'm not super aggressive. I recently did a really big one where I actually did an osteotomy on 4. I fused 2 and 3, and I fused the first because there was a huge diastasis between 4 and 5 that I closed down, and I worked from lateral to medial to create space to fix the bunion and stuff for a lady who had a lot of midfoot arthritis. But I'm hard pressed, even though the foot looks a little wonky, if you do a bunion on someone with metaductus, if they don't have a lot of arthritis, to jump in there and start fusing it or cutting it.
All right. What about
make
everybody?
a
Let me just go through
metatarsal
the
that doesn't hurt,
post-operative
painful
protocols. Sorry, Dr. Campbell, did I cut you off there?
I think he's got the glitch.
Okay.
Hey, guys.
We're losing you there a little bit. Well, let's move on to post-op protocols, and then if he has more to add when we get him back, we can go there. Scott, what are your post-op protocols for these midfoot lesser TMT cases?
Again, this is always an evolution, but I do keep them non-operative for a couple of weeks, or non-weight bearing, for a couple of weeks after, if I'm doing the whole midfoot. And then when they come back in a couple of weeks, I'll let them weight bear on their heel initially, and then full weight bearing by about 4 to 6 weeks, just depending on the patient.
Yeah, I'm usually splinting these people for 2 to 4 weeks, depending on their skin healing and things of that nature. And then usually I don't let them walk on it until at least 4 weeks. Sometimes I push it more to 6 weeks before I'll even think about letting them put it on the ground, even with a protected boot or anything like that. Just scares me too much. And they're an extra 2 weeks never hurt anyone on the fusion.
How about you, Mike?
Sorry about that, guys. I lost my internet there.
No worries.
So I'm super aggressive at this. I put the people in a post-op shoe initially, and I have them heel weight bear on it immediately. And as soon as they're dressing small enough that it fits into a cam boot, I switch them into a cam boot. That protocol has been born out of grossly non-compliant patients who utterly disregarded when I told them to stay off it, walked on it, and did fine, if not better than some of my compliant patients. And that's kind of how I've modified things over the years. I think the one big thing is if you do that, a lot of times when those folks are walking, especially if they're heel weight bearing and stuff, they'll take their toe and they'll kind of pull their hallux up. So especially if I'm done something with the first tray, I encourage them to begin passive range of motion exercises to avoid a dorsiflexion contracture of the great or even the lesser toes as well, because I think keeping those tendons gliding across the surgical site is a good move.
Yeah, I agree with you. That first case that was of mine that we presented, like I said, she came in at 4 weeks in her boot. She was supposed to be in her splint, and she's doing fantastic. So maybe we should be pushing them a little harder. I'm not sure.
Scott and/or Beverly, do we have any questions for the panel?
There was a question earlier. Someone typed in asking about staple leg lengths and had to decide which one. So if it's all right with you guys, I'll jump on that one. So really there's the staple nomenclature for crossroads can be a little confusing if you don't know what it is. So I'll just kind of back up. So usually they talk about a 15 or an 18 staple or a 20 staple, and what they're referring to is the bridge length, the distance between the tongs. Then the other numbers that they throw out are the length of the tongs, and so really the 15 or the 18 bridge length is going to be determined by which plate you choose. So for a really small petite foot with a small cuneiform, having that 15 is advantageous. It just keeps the construct 3 millimeters tighter. The leg length, what I try to do is get the longest leg length that I can. I usually drill my staple hole bicortical. And then if I'm not sure, you can use the guide. It has the laser line, so you can see where you're at when you punch through that other cortex. If not, you can always throw a depth gauge in to see. But typically for a second metatarsal, an 18 by 18 usually is fine. For the third, sometimes that's when you get down to maybe the 18-14.
Any other questions that we have out there?
It looks like somebody just typed in, can the system be used for metatarsus adductus? Or is it just in situ second and third arthrodesis? I think that you could use this system the way it is for that. As far as cutting the cuneiform, it would be more difficult to cut the base of the metatarsal. We are in development of a system that will allow you to utilize this for metaductus, and hopefully that'll be out soon.
You can do it. I did it recently. There's a little trick. What you can, if you cut the cuneiform, then what you can do is you can swing the metatarsal to the position that you want, and then pin the metatarsal and cut that side. A lot of times with metaductus, your metatarsals are quite long. If you look at those X-rays that we showed earlier, so a lot of times you'll want to do a couple of cuts to get down to the length you want, which works because it also does the angular correction for you as well. I think there's something going to be designed specifically for that in the future, but the current system, there is a workaround that works pretty nicely for it.